This presentation is on tuberculosis. This is an exemplar of our gas exchange concept. TB is an infectious disease caused by Mycobacterium tuberculosis. It usually involves the lungs but can affect any organ, including the brain, kidneys, and bones. About 25% of the world's population is infected with TB, and the incidence of TB worldwide declined until the mid-1980s. We are now seeing increasing rates of TB. This is attributed to HIV disease and the emergence of drug-resistant strains of M. tuberculosis, and TB is the leading cause of mortality in patients with HIV. TB occurs disproportionately in the poor, underserved, and minorities. People most at risk include the homeless, residents of inner-city neighborhoods, foreign-born people, and those living or working in institutions, IV drug users, overcrowded living conditions, less than optimal sanitation, and those with poor access to health care. Immunosuppression from any cause, such as HIV, cancer, long-term use of corticosteroids, increases the risk for active TB infection. TB is a gram-positive, aerobic, acid-fast bacillus. It is usually spread from person to person by airborne droplets that they release when they're breathing, talking, singing, sneezing, and coughing. Evaporation leaves small droplet nuclei suspended in the air for minutes to hours. Another person then inhales the bacteria. Humans are the only known reservoir for TB, and it is not highly infectious. Transmission requires close contact and frequent or prolonged exposure. It's not spread by touching, sharing food utensils, kissing, or any other physical contact. Factors that influence transmission include the number of organisms expelled in the air, the concentration of those organisms. So small spaces with limited ventilation would mean higher concentrations, the length of time of exposure, and the immune system of the exposed person. Once inhaled, these small droplets lodge in bronchioles and alveoli. A local inflammatory reaction occurs and the infection is established. Most immunocompetent adults infected with TB can completely kill the mycobacteria. Only 5 to 10% develop active TB infection when the bacteria begins to multiply months or years later. Once a strain of TB develops resistance to first-line drug therapy, it is defined as a multi-drug resistant TB. Extensively drug-resistant TB is a rare type of MDR TB for which it is resistant to any type of medication, the fluoroquinolone, and at least one second-line drug. Resistant results from several problems, including incorrect prescribing, lack of case management, and non-adherence to the prescribed regimen. This is one method for classifying TB, the American Thoracic Society. You do not need to know this by heart, but it is one that is used, but just not as frequent. This is the classification system that's usually more commonly used. It also classifies TB by its presentation, whether it's pulmonary or extrapulmonary. Primary TB infection starts when the bacteria are inhaled and triggered an inflammatory reaction. Most people have effective immune responses that encapsulates the organisms for the rest of their lives, preventing the initial infection from progressing to disease. If the initial immune response is not adequate, the body cannot contain the organism. As a result, the bacteria replicate and active TB disease results. When active disease develops within the first 2 years of infection, it is called primary TB. People with HIV are at greatest risk for developing active TB. Post-primary TB or reactivation TB is defined as TB disease occurring 2 or more years after the initial infection. If the site of TB is pulmonary or laryngeal, the person is infectious and can transmit the disease to others. Latent TB occurs in a person who does not have active TB disease. People with LTBI have a positive skin test but are not symptomatic. They cannot transmit the TB bacteria to others, but can develop active TB disease later on. Immunosuppression, diabetes, poor nutrition, HIV, glucocorticoid therapy, pregnancy, stress, and chronic disease can reactivate the disease. Treatment of LTBI is as important as primary TB. Some clinical manifestations for TB would be an acute, sudden presentation of the TB. They have a high fever. Another piece is the night sweats. They have chills, generalized like flu-like symptoms. They can have pain in their chest. They can have a productive cough. They'll have crackles or advantageous breath sounds. Immunosuppressed people like HIV and older adults are less likely to have fever and other signs of infection. So with HIV, carefully assess respiratory problems and rule out PJP or opportunistic diseases. And older adults, the change in the cognitive function may be the only initial sign. So if they have a change of, maybe they've suddenly gotten confused, or they have some other type of, they were more alert, now they're not, they seem to be a little more confused and not understand things, that would be another sign. Extrapulmonary TB manifestation depends on the organs in which it is affected. There's a few diagnostic studies on the tuberculin skin test, the TST. It's also called Mantoux test. This is a screening for TB. You guys all had this done when you were coming into the program. You had to have the TB test. They have that intradermal where they give you like that little blip, and then they look to see if you have a reaction to it. A positive is greater than or equal to 5 millimeter in duration in low risk individuals. So if you just kind of refer back to what you guys did before getting into the program. Interferon Y release assay is a screening tool. It's a blood test. It detects INF gamma release from T cells in response to that M tuberculosis. It includes the quantiferon, TB gold in tube, and T-spot. This is more of a blood test that they can take, and often if you're doing like regular labs for your doctor and you need to be screened, they can do it as well at that particular time. Often the expense of it is what kind of makes it to where people don't necessarily use it. A chest X-ray can be used. It cannot make a diagnosis solely based on an X-ray. But it may appear normal in a patient with TB. That's why they can't use it as the definitive. What they might see in the chest X-ray would be like upper lobe infiltrates, lymph node involvement, pleural or pericardial infusions. And then we have bacteriological studies. This is the gold standard. This is the sputum cultures. 3 consecutive sputum samples at 8 to 24-hour intervals at least. We want the specimens in the morning. We don't want them in the afternoon. And a patient will not come off of precautions or anything like that until we've had 3 consecutive negative. Most patients are treated as outpatients. Many people can continue to work and maintain a normal lifestyle. Infectious for the first 2 weeks after starting treatment if sputum is positive. So patients with sputum smear positive TB are considered infectious for the first 2 weeks after starting treatment. You want to advise these patients to restrict visitors. Don't have like a house party. Avoid travel. Don't go other places. Public transportation. Don't get on a bus or a train during these first 2 weeks because you have there's a higher risk that you could infect others. Teach them the importance of good hand hygiene and oral hygiene. And then typically we don't, we'll have hospitalization may be needed for the severely ill or debilitated patient, or if they have other comorbidities. Sometimes that can cause the patient to have to be hospitalized as well. But overall, they are an outpatient basis that we care for them. Active TB disease, the drug therapy that we typically use is done in 2 phases. The first phase includes those 4 medications. It's important for you to know the side effects here. Increases risk for hepatotoxicity. Rifampin, it is really important that we talk to patients and let them know that their body fluids will be an orange colored. There would be nothing scarier than if I didn't know that and all of a sudden I have, orange teardrops. That would be a cause for concern. And so once we have the 4 medications that they go through in the first phase, then we go into the continuation phase. Isoniazid and rifampin are the 2. And patients should be taught about adverse side effects and when to seek medical attention. Non-viral hepatitis is a major side effect for 3 or 4 first-line drugs. So we would want to make sure that we are monitoring their liver function tests. Alternatives are available for those who develop a toxic reaction to the primary drugs. For MDR-TB, the sensitivity test determines which of the drugs, 5 drugs for at least 6 months. These patients have to take these medications for a long period of time, 6 months on all of these medications. And then the continuation, 4 drugs for 18 to 24 months. So you can see it's a long, drawn out period of time with this multi-resistant. Biggest problems that we have with TB is if you can think about the population, right, that are higher risk. So we have homeless people, people who live in institutions. So if we take people who are living in shelters, things like that, they are at a higher risk. But think about how are we going to get them the medications that they've got to take for a substantial period of time? So they have something that's called directly observed therapy. And so non-adherence is a major factor of MDR-TB, and we have treatment failures because of it. So the DOT, what it does is it brings patients or people with TB to a particular location, and it's directly observed that they take the medications. It's just really hard because when you have homeless people who live on the streets, they're not always in the same locations. So this is one of the reasons that we have such a higher incidence of non-adherence to the medication regimen. It's expensive, but for public health purposes, it really does strengthen by doing DOT. It strengthens the adherence to the medication. In many a times, what they'll do is they'll put a clinic in an area where it's got a higher incidence of TB, and they will come to that clinic. It's costly, and most of these people do not have insurance, so this is something that's funded. And like I said, a lot of public health nurses will handle this. I actually think in Tampa, we have a TB clinic that people can go to that is really just geared toward adherence to the medication regimen. In people with LTBI, drug therapy helps prevent a TB infection from developing into an active TB disease. Because a person with LTBI has fewer bacteria, treatment is much easier. Usually only one drug is needed. The standard treatment regimen for LTBI is 9 months of isoniazid, and it is an effective and inexpensive drug that the patient can take orally. This plan is also recommended for patients with HIV and those with fibrous lesions on chest x-ray. While the 9-month plan is more effective, adherence issues may take a 6-month plan preferable. So 6 to 9 months is a long period of time. There is also an alternative 3-month regimen, and it may be used for otherwise healthy patients who we presume are not infected with MDR bacilli. Patients who are resistant to isoniazid may receive 4-month therapy with rifampin. BCG vaccine is a live strain of Mycobacterium bovis. The vaccine is given to infants in parts of the world with a high prevalence of TB. In the United States, it is rarely used because of the low risk for infection, the vaccine's variable effectiveness against adult pulmonary TB, and the potential interference with TST reactively. The BCG vaccine should be considered only for select patients who meet specific criteria. They stopped doing this many years ago. It was, I want to say somewhere around like 55 years ago here in the United States. They stopped giving this because it really wasn't needed. And you'll know if people have it because they have like this indentation in their upper arm. However, if you have somebody who was born in a different country and they have now moved to the United States, they may actually have that because that is something that in their country they still do. So on your assessment, you really want to ask the patient questions about any previous history of TB, any type of chronic illnesses, or any immunosuppressive diseases or medications that they may or may not be or may be taking. Obtain a social and occupational history to determine the risk factors for TB transmission. If they've previously lived in an institution, think about like prisons or jails or detention facilities, things like that. People are in close quarters. Assess the patient for if they've got a productive cough. Do they have night sweats when they're sleeping? Do they wake up wet? Do they wake up feeling like they're drenched? Fever, weight loss, any type of chest pain that they might have. Abnormal lung sounds. Do they have advantageous sounds? Are there absent sounds? If the patient has a productive cough, early morning is the best time to collect that sputum specimen for the AFB smear. In the hospital, we always want them first thing in the morning. We don't want them later in the day. We try really hard to get that first one because they've been sleeping, right? And they should be able to give you a pretty good sputum sample. So some of our nursing diagnoses that we would use: impaired respiratory function, infection, deficient knowledge, lack of knowledge. Sometimes we could use non-compliance, non-adherence to the medication regimen kind of thing. Some goals that we would have for the patients is to have the normal lung function, adhere to that treatment plan. And that seems to be our biggest challenge, is that people it's a long period of time. And so it's very hard for patients, to stay with it. And this is what then, when they don't carry forward and do the entire regimen, that's how they end up with that multi-drug resistant TB. Take measures to prevent the spread of TB. So like I had said in a previous slide, those first 2 weeks, make sure that they're kind of staying at home. They're not getting around other people. They're not in close proximity as far as I would not want to be on an elevator with somebody, or I wouldn't want to be on a bus with somebody who has that within the first 2 weeks. So we make sure that we provide that patient education. And we're really, as a goal, looking for to have no reoccurrence. All right, our nursing implementation, health promotion. Our ultimate goal worldwide is that nobody has TB, right? That's a big global thing. Selective screening programs to detect TB in high-risk groups. So people who are living in homeless shelters, people who are in institutions, those would be areas that we would have screenings for. Treatment of the LTBI to decrease any type of carriers, even though they don't show signs of it, that they could give it to somebody else. Positive TST results, so like the X-ray, that would be some of our diagnostic tests. TB, reportable to public health authorities to identify contacts and risks to the community. So this would be one of our reportable things, like HIV, it has to be reported to the to public health. Usually, like for us we live in Hillsborough County, it would have to go to the Hillsborough County location. Address any social determinants of TB. So that could be, really with the underserved, living in shelters, things like that. And improve access to healthcare and education. So, we want to improve that people can, get to places that have the medication, that they have access to those medications, so that they can get better. In acute care, make sure that you have the patient on airborne isolation, single occupancy room, and so 6 to 12 airflow exchanges per hour. Healthcare workers have to wear high efficiency, like HEPA masks, and it's fit tested. So this would be like your N95 masks. Immediate medical workup if you come in contact with somebody. If a patient was not under the precautions, and then you turned around and they later determined that they needed to be, that we make sure that we have those cultures done, and we take care of our medical personnel. That we have the drug therapy available and teach the patient to prevent the spread, kind of like what I was saying about not going out in the first 2 weeks, but cover their nose and mouth with tissue and coughing, sneezing, or producing sputum. Dispose in a trash can. Don't leave it on a counter, or you can flush it down the toilet. Hand washing after handling sputum soiled tissues. Patient wears face mask if outside of a negative pressure room. Identify and screen close contacts. When they go home, they may go home even if cultures are positive. Monthly sputum cultures, 2 consecutive negative cultures equals non-infectious. Teach patient how to minimize exposure to others. Teach them the importance of adherence to the patient and caregiver, like make sure that they are washing their hands, and that they're doing the things to ensure that they're not infecting anybody else, and that they are taking care of themselves as well, making sure the medications are being taken the way that they should be. You want to notify the public health department and teach symptoms of reoccurrence. So if they start having some of those manifestations again, they need to seek care. And then if they're smokers, you need to talk to them about smoking cessation. So some of the expected outcomes that we want for these patients is resolution of the disease, that they go back to having normal lung function and without any complications, and no further transmission of TB, so that they've kept everyone in the community and themselves and their family members safe.